Welcome to MedStudios, your go-to destination for excellence in medical education. Today, we're diving deep into one of the most high-yield and clinically rich subjects in all of medicine, ophthalmology. This masterclass has been fully updated with 2024 and 2025 clinical guidelines and cutting-edge research, making it perfectly tailored for candidates sitting the USMLE, MRCP, PLAB, AMC, MBBS, and BDS examinations. Ophthalmology is one of those beautiful subjects that doesn't stay within its own boundaries. It bleeds into neurology, endocrinology, rheumatology, pediatrics, and even oncology. The eye is literally a window into the entire human body, and that's exactly why boards love testing it so much. Here's your very first board pearl to lock in right now. Ophthalmology intersects with virtually every body system. Neurological disorders produce visual field defects. Diabetes and hypertension leave their fingerprints on the retina. Autoimmune conditions like multiple sclerosis and sarcoidosis manifest in the eye before anywhere else. Mastering ophthalmology doesn't just earn you points in the eye section, it earns you points across multiple disciplines. So get comfortable, grab a pen, and let's build your ophthalmology foundation from the ground up. By the end of this video, you will have the clinical knowledge, the anatomical frameworks, and the board strategies to score confidently on every ophthalmology question that comes your way. Let's go!
Before we dive into the clinical content, let's understand the scale of the problem, because these epidemiological facts are pure gold on board examinations. Let's start with cataracts. Cataracts are the single leading cause of reversible blindness worldwide. Over 20 million people are affected, and cataracts account for approximately 51% of all blindness globally. The critical word here is reversible, because surgical treatment can restore vision completely. That distinction is enormously important for your exams. Next is glaucoma, and this one is the leading cause of irreversible blindness globally. Over 70 million people are affected today, and that number is projected to climb to a staggering 111.8 million by 2040. Unlike cataracts, the damage from glaucoma cannot be undone, which is why early detection is everything. Age-related macular degeneration, or AMD, is the leading cause of central vision loss in patients over 50 years of age, particularly in high-income countries. It robs patients of their fine detail central vision while leaving peripheral vision intact. And finally, diabetic retinopathy is the leading cause of preventable blindness specifically in working-age adults worldwide. The keyword there is preventable, meaning good glycemic control and timely screening can stop it in its tracks. Your exam board pearl? Always differentiate. Cataract equals reversible. Glaucoma equals irreversible. And diabetic retinopathy equals preventable working-age blindness. Boards test this distinction relentlessly.
Now let's build your anatomical foundation, because you cannot diagnose what you don't understand structurally. The eye, or globe, is organized into 3 concentric layers. The outermost fibrous layer consists of the cornea anteriorly and the sclera posteriorly. The cornea itself has 5 distinct layers: epithelium, Bowman's layer, the stroma, which makes up 90% of the cornea's thickness, Descemet's membrane, and the endothelium. That endothelium is a single-cell layer with no regenerative capacity. Once it's lost, it's gone. The middle layer is called the uvea, and it consists of 3 structures: the choroid, the ciliary body, and the iris. The ciliary body is incredibly important because it produces the aqueous humor. Aqueous humor flows in a very specific circuit, and you need to know this circuit for glaucoma questions. It's produced at the ciliary processes, flows through the posterior chamber, then through the pupil into the anterior chamber, drains through the trabecular meshwork into the canal of Schlemm, and then into the episcleral veins. Blockage anywhere along this circuit raises intraocular pressure. On the right side of this slide, you can see the retinal architecture. Light travels through ganglion cells first, then bipolar cells, and finally hits the photoreceptors, the rods and cones at the very back. The retinal pigment epithelium, or RPE, underlies the photoreceptors and performs 3 critical functions: phagocytosis of photoreceptor outer segments, vitamin A recycling, and forming the outer blood retinal barrier. Your board pearl here, the fovea centralis, the very center of the macula, contains only cones, is completely avascular, and is nourished exclusively by the choriocapillaris beneath the RPE. Rods, numbering 120 million, dominate the periphery and contain rhodopsin, your low-light vision pigment.
This is one of the most tested topics in all of medicine, the visual pathway and what happens when you damage it at different points. The pathway runs like this. Retinal photoreceptors send signals through bipolar cells to ganglion cells, then along the optic nerve, which is cranial nerve 2, to the optic chiasm, then via the optic tract to the lateral geniculate nucleus of the thalamus, then through the optic radiations to the primary visual cortex in the occipital lobe. At the optic chiasm, nasal fibers from each retina cross to the opposite side, while temporal fibers remain ipsilateral. This crossing is what creates the classical visual field defects. Lesion number 1. Damage to a single optic nerve causes complete monocular blindness in that eye only. Lesion 2. Damage to the central optic chiasm, classically from a pituitary adenoma pressing upward, knocks out the crossing nasal fibers from both eyes, producing bitemporal hemianopia, the classic tunnel vision. Lesion 3. The optic tract, which is post-chiasm, carries fibers from the same visual field of both eyes. Damage here causes contralateral homonymous hemianopia. Lesion 4. The Meyer loop through the temporal lobe carries inferior retinal fibers. Damage here causes a contralateral superior quadrantinopia, remembered as pie in the sky. Lesion 5. Parietal lobe damage produces contralateral inferior quadrantinopia, pie on the floor. And lesion 6, the big board pearl. Occipital cortex damage causes contralateral homonymous hemianopia with macular sparing. Why? Because the macular representation in V1 has a dual blood supply from both the middle cerebral artery and the posterior cerebral artery, protecting it even when the surrounding cortex is ischemic. Now let's tackle pupillary abnormalities, another absolute favorite on board examinations. First up is RAPD, relative afferent pupillary defect. This is detected using the swinging flashlight test. When you swing the light to the affected eye, instead of constricting, the pupil paradoxically dilates. The mechanism is damage to the ipsilateral optic nerve or extensive retinal disease, which reduces the afferent signal. The direct reflex is weak, but the consensual reflex from the normal eye is intact. Horner syndrome gives you the classic triad of miosis, small pupil, plus ptosis and anhidrosis, all on the same side. It results from interruption of the sympathetic chain. Think Pancoast tumor at the lung apex, carotid dissection, or lateral medullary syndrome. The cocaine test confirms it. A normal eye dilates with cocaine drops because cocaine prevents noradrenaline reuptake. A Horner eye does not dilate because there's no sympathetic signal to amplify. CN3 palsy is surgical versus medical, and this is a critical distinction. Surgical CN3, caused by aneurysm compression, involves the pupil, causing mydriasis. Why? Because the pupilomotor parasympathetic fibers travel on the outside of the nerve and are compressed first by external pressure. Medical CN3, from microvascular ischemia in diabetes, spares the pupil because ischemia hits the core of the nerve first. Addy's tonic pupil gives you a large, poorly reactive pupil with absent deep tendon reflexes, Holmes-Addy syndrome. The pupil is hypersensitive to dilute 0.1% pilocarpine due to postganglionic parasympathetic denervation. And the Argyll-Robertson pupil? Bilateral, irregular, migiotic pupils that accommodate but do not react to light. The classic mnemonic is ARP, accommodation retained, pupils fixed. Classic for neurosyphilis, also seen in diabetes. Refractive errors affect over 2.2 billion people worldwide, making them the most common eye conditions on the planet. Let's break them down with precision. Myopia, or short-sightedness, occurs when the eyeball is too long or the cornea too curved. The image focuses in front of the retina.
You correct it with a concave or minus diverging lens. Think of it as pulling the image back to where it belongs. Hyperopia, or long-sightedness, is the opposite. The eyeball is too short, and the image focuses behind the retina. You correct it with a convex, or plus, converging lens. In young patients, the ciliary muscle can compensate through accommodation, making hyperopia latent. Astigmatism occurs when the cornea has an irregular curvature. Instead of being perfectly spherical, it curves more in one direction. This creates multiple focal points and blurred vision at all distances. The correction is a cylindrical lens, which only bends light in one plane. Presbyopia is distinct and important. It is not hyperopia. Presbyopia is loss of accommodation due to progressive hardening and loss of elasticity of the crystalline lens, beginning around age 40 to 45. You cannot squeeze a hard lens to change its focal power. You correct presbyopia with plus lenses for near vision, reading glasses. Now for the 2024 headline, the global myopia epidemic. Myopia prevalence is projected to hit 50% of the world's population by 2050. High myopia, defined as greater than -6 diopters, dramatically increases the risk of retinal detachment, myopic macular degeneration, and glaucoma. Current 2024 interventions include low-dose atropine eye drops at 0.01 to 0.05%, based on the LAMP2 study. Orthokeratology and DIMS lenses showing 52% slowing of progression, and more than 2 hours of outdoor time daily, which triggers retinal dopamine release and slows axial elongation.
Glaucoma is the leading cause of irreversible blindness worldwide, affecting over 76 million people. And understanding the distinction between open angle and angle closure is absolutely essential. Primary open-angle glaucoma, or POAG, is the silent destroyer. The drainage angle is open. You can see the trabecular meshwork on gonioscopy, but the meshwork itself is dysfunctional, causing reduced outflow and slowly rising intraocular pressure. Patients are completely asymptomatic in the early stages. They lose peripheral vision first, presenting as arcuate scotomas, nasal steps, and paracentral defects, while central vision is preserved until very late. The optic disc shows characteristic cupping, with a vertical cup-to-disc ratio greater than 0.6. The 2024 board pearl here is enormous. NICE 2022 guidelines, backed by the LIGHT trial, now recommend selective laser trabeculoplasty, SLT, as the first-line treatment option for newly diagnosed POAG. This is a paradigm shift away from lifelong eye drops. SLT applies laser energy to the trabecular meshwork to improve drainage. For patients still requiring drops, the step-up is prostaglandin analogs first, latanoprost, bimatoprost, then beta blockers like timolol, then carbonic anhydrase inhibitors. Target IOP reduction is 25 to 30% from baseline. On the other side is primary angle closure glaucoma, a medical emergency. Here, the peripheral iris physically blocks the drainage angle. The presentation is dramatic. Sudden, severe unilateral pain, nausea and vomiting, halos around lights, dramatically reduced vision, and a fixed mid-dilated pupil, measuring 4 to 6 millimeters, with a hazy cornea from edema. IOP may explode to 50 to 70 millimeters of mercury. Emergency triage, IV acetazolamide immediately, then topical timolol and apriclonidine, followed by pilocarpine 2% once the IOP begins to fall. Definitive treatment is ND-YAG laser peripheral iridotomy to create an alternative drainage route, and the fellow eye should receive prophylactic iridotomy too.
Cataracts account for 51% of global blindness, and the beautiful thing is that every single one of those cases is treatable. Let's dissect the types. Age-related senile cataracts come in 3 flavors. Nuclear cataracts cause a myopic shift. Patients may suddenly be able to read without glasses before vision deteriorates into a brunescent brown opacity. Cortical cataracts appear as spoke-like opacities radiating from the periphery. And posterior subcapsular cataracts, PSC, are the most symptomatic. They sit right in the path of light entering the eye, causing severe glare and disproportionate loss of near vision. Congenital cataracts are caused by Torch's infections. Rubella is the classic board answer.
as well as galactosemia, which causes an oil droplet cataract, Down syndrome, and Low syndrome. The critical management point is the absent red reflex. This is a medical urgency. Congenital cataracts must be treated within 6 to 10 weeks of diagnosis to prevent deprivation amblyopia from setting in permanently during the critical visual development period. Metabolic and drug-induced cataracts are rich territory for exam questions. Diabetes causes a snowflake cortical cataract in acute hyperglycemia. Wilson's disease causes a sunflower chalcosis cataract. And corticosteroids, both systemic and inhaled, classically cause posterior subcapsular cataracts, causing severe glare and near vision loss disproportionate to distance vision. Surgical management is phacoemulsification. Ultrasound energy is used to emulsify and aspirate the lens, followed by implantation of a foldable intraocular lens. IOL power is calculated using biometry, and the Kane formula is preferred in 2024 for its superior accuracy. Complications to know? Posterior capsule opacification. The most common long-term complication is treated with ND-YAG laser capsulotomy. And endophthalmitis is rare but devastating, requiring immediate intravitreal antibiotics.
Diabetic retinopathy is the leading cause of new-onset blindness in working-age adults in high-income countries, and it is entirely preventable with good glucose control and timely screening. The pathological cascade begins at the microvascular level. Chronic hyperglycemia causes parasite loss from retinal capillaries. Without parasites, the capillary walls weaken, forming microaneurysms, which are the very first sign of diabetic retinopathy. These microaneurysms leak, causing increased vascular permeability and retinal edema. As the disease progresses, we classify it into stages. Mild non-proliferative diabetic retinopathy, NPDR, shows microaneurysms only. In moderate NPDR, you add dot and blot hemorrhages, hard exudates from lipid leakage arranged in a circinate pattern, and cotton wool spots, which represent nerve fiber layer infarcts. Severe NPDR is defined by the 4-2-1 rule, 20 or more hemorrhages in 4 quadrants, or venous beading in 2 or more quadrants, or intraretinal microvascular abnormalities, ORMA, in 1 or more quadrant. Meeting any one of these criteria means the eye is at high risk of progressing to proliferative disease. In proliferative diabetic retinopathy, new fragile vessels grow on the disc, NVD, or elsewhere on the retina, NVE. These vessels bleed easily into the vitreous, causing sudden floaters and vision loss. Tractional retinal detachment can also occur. The treatment landmark for 2022 onwards is faricimab, brand name Vabysmo. It is the first bispecific antibody targeting both VEGF and angiopoietin-2. It is approved for both diabetic retinopathy and diabetic macular edema, with the major advantage of extended dosing intervals, up to every 16 weeks, reducing the injection burden significantly. And remember your critical board pearl. Diabetic macular edema, not proliferative disease, is the leading cause of visual loss in type 2 diabetes. It is defined as retinal thickening within 500 micrometers of the fovea.
Age-related macular degeneration is the leading cause of irreversible central visual loss in people over 50 in high-income countries. It affects the macula, responsible for fine detail, reading, and color recognition, while leaving peripheral vision intact. This is important. AMD causes central blindness, not total blindness. AMD exists on a spectrum. Dry AMD, also called atrophic AMD, accounts for 85 to 90% of cases. It begins with the accumulation of drusen, yellow-white deposits of waste material between the retinal pigment epithelium and Bruch's membrane. Small hard drusen carry low risk, but large, soft, confluent drusen signal significant risk for progression to geographic atrophy, the irreversible end stage of dry AMD, where patches of RPE and photoreceptors are permanently lost. Wet AMD, or neovascular AMD, accounts for only 10 to 15% of cases, but causes the majority of severe vision loss. In wet AMD, abnormal new blood vessels grow from the choroid, under the retina, called choroidal neovascularization, and leak fluid, blood, and lipids. The hallmark symptom is metamorphopsia.
straight lines appearing wavy or distorted, detected on the Amsler grid. Now for the 2023-2024 breakthroughs that are absolutely guaranteed to appear on upcoming boards. For wet AMD, faricimab and high-dose aflibercept 8 mg, EYLEA HD, now offer extended dosing, up to every 12 to 16 weeks. But the true historic milestone is for dry AMD. For decades, there was no approved treatment for geographic atrophy. In 2023, the FDA approved 2 complement inhibitors. Pegcetacoplan, brand name Syfovre, is a C3 complement inhibitor that reduces geographic atrophy growth by approximately 20%. And avacincaptad pegol, brand name Izervay, is a C5 inhibitor that reduces GA growth by approximately 35% at 12 months. These are the first ever disease-modifying treatments for dry AMD, a landmark moment in ophthalmology. For prevention, the AREDS2 formula, containing zinc, copper, vitamin C and E, lutein, and zeaxanthin, reduces the risk of progression in intermediate AMD by 25%.
This slide covers 3 posterior segment emergencies that you must recognize instantly because delayed treatment means permanent vision loss. First, retinal detachment. The presenting symptoms are sudden onset of floaters from posterior vitreous detachment, followed by photopsia, which are flashes of light from traction on the retina, and then a curtain or shadow sweeping across the visual field towards the center. The most common type is rhegmatogenous retinal detachment, where a tear or hole in the retina allows liquefied vitreous to seep underneath, physically separating the neurosensory retina from the RPE. Risk factors include high myopia, trauma, and prior cataract surgery. The critical distinction on exam is macula off versus macula on detachment. Once the fovea detaches, the risk of permanent central visual loss escalates dramatically, making surgical urgency a priority. Second emergency, central retinal artery occlusion, CRAO. Think of this as a stroke of the eye. The patient presents with sudden, painless, profound monocular vision loss. An RAPD is present. Fundoscopy shows the pathognomonic cherry red spot at the fovea. This occurs because the retina becomes pale and edematous from ischemia, while the thin fovea, nourished independently by the choroid, remains red. The cherry red spot is pure bored gold. It also appears in Tay-Sachs disease and Niemann-Pick disease for the same reason, a pale surrounding structure contrasting with the choroid-supplied fovea. Third emergency, retinitis pigmentosa. This is the most common hereditary retinal dystrophy. Patients develop night blindness first, nyctalopia, because rods degenerate before cones. Progressive tunnel vision follows as the peripheral retina is destroyed. Classic fundoscopy shows bone spicule pigmentation, attenuated vessels, and waxy disc pallor. The 2024 treatment update, Luxturna, Voratine Naparvovac, is the gene therapy approved for RPE65 gene mutations, with 7-year durability data now confirming sustained improvement in visual function.
The red eye is one of the most common presentations in medicine and one of the most high yield on board exams. Your ability to differentiate these conditions using clinical features alone is what separates a great clinician from an average one. Starting with conjunctivitis. Viral conjunctivitis, most commonly adenovirus, gives watery discharge, follicles on the palpebral conjunctiva, and starts in one eye before spreading to the other. It is highly contagious and self-limiting over 7 to 14 days. Bacterial conjunctivitis produces mucopurulent discharge, the classic sticky eye in the morning. The most dangerous bacterial cause is Neisseria gonorrhea, which presents hyperacutely within 24 hours with profuse purulent discharge and carries a real risk of corneal perforation. Allergic conjunctivitis is always bilateral, intensely itchy, and associated with chemosis and papillae on the tarsal conjunctiva. Corneal ulcer, especially in contact lens wearers, raises the specter of Pseudomonas aeruginosa, which is aggressive and sight-threatening. Key point from your slide: do not patch a corneal abrasion. Patching delays healing and increases infection risk. Anterior uveitis, or iritis, presents with circumcorneal flush, deep aching pain, photophobia, an irregular meotic pupil, and chorotic precipitates in the anterior chamber.
The strong association is with HLA-B27 positive conditions, ankylosing spondylitis, reactive arthritis, inflammatory bowel disease, and psoriasis. Scleritis versus episcleritis. This is a high-yield distinction. Episcleritis is mild, sectorial, and blanches with phenylephrine drops. The superficial vessels constrict. Scleritis is severe, causes boring deep pain, appears deep violet red, does not blanch. The deep vessels are unaffected by phenylephrine, and is associated with serious systemic diseases like rheumatoid arthritis and granulomatosis with polyangiitis. Scleritis can cause scleral melt and perforation if untreated.
Pediatric ophthalmology is built around one fundamental concept, the critical period of visual development, which spans from birth to approximately 7 to 8 years of age. During this window, the visual cortex is actively forming binocular connections. Any disruption, from strabismus, unequal refractive errors, or visual deprivation, can cause permanent amblyopia. Retinoblastoma is the most common intraocular malignancy of childhood. The classic presenting sign is leukocoria, a white pupillary reflex, often noticed in photographs when one eye lacks the normal red reflex. Strabismus is the second most common presentation. The genetic basis is the RB1 gene on chromosome 13q14, the classic Knudsen two-hit hypothesis. Germline mutations cause bilateral, multifocal hereditary disease. Somatic mutations cause unilateral, non-hereditary disease. Amblyopia, the lazy eye, affects 2 to 5% of the population. It results from abnormal visual experience during the critical period, preventing the visual cortex from developing normal acuity in one eye. The most common cause is strabismus, followed by anisometropia, unequal refractive errors between the two eyes. Treatment: correct the underlying cause first, then patch the better eye to force the amblyopic eye to develop. Atropine penalization of the better eye is an alternative. Strabismus. The gold standard clinical test is the cover test. Esotropia is inward deviation, exotropia is outward. Any new onset esotropia in a child must be treated with high suspicion for a CN6 palsy, which could indicate an intracranial mass applying pressure. Retinopathy of prematurity affects premature infants under 31 weeks gestation or under 1,500 grams who are exposed to supplemental oxygen. The 2024 update: anti-VEGF agents, specifically bevacizumab or ranibizumab, are now first line for type 1 ROP based on the RAINBOW and BEAT ROP trial data, preferred over laser photocoagulation.
This slide encapsulates one of the most beautiful aspects of ophthalmology: the eye as a window into systemic disease. Each finding tells a story about what is happening throughout the entire body. In multiple sclerosis, the most common ocular manifestation is optic neuritis, presenting with subacute unilateral visual loss, pain on eye movement, red color desaturation, and an RAPD. The landmark ONTT trial established that up to 50% of optic neuritis patients will develop MS within 15 years. MS also causes internuclear ophthalmoplegia, INO, from a lesion in the medial longitudinal fasciculus, causing an adduction palsy in the ipsilateral eye and nystagmus in the contralateral abducting eye. In thyroid eye disease from Graves' disease, the inflammatory infiltration of the orbital fat and extraocular muscles, particularly the inferior rectus, causes proptosis, lid retraction, lid lag, diplopia, and chemosis. The most dangerous complication is compressive optic neuropathy from increased orbital pressure. This is a surgical emergency requiring urgent orbital decompression. In hypertensive retinopathy, you grade the severity by fundoscopic findings. Grade 1 shows silver or copper wiring from arteriolar wall thickening. Grade 2 adds AV nipping, where arterioles compress veins at crossing points. Grade 3 adds flame hemorrhages and cotton wool spots. Grade 4, the most severe, shows papilledema, indicating malignant hypertension, a medical emergency. In sarcoidosis, the classic finding is granulomatous anterior uveitis with large mutton fat keratotic precipitates. Optic nerve granulomas can also occur. In rheumatoid arthritis, keratoconjunctivitis sicca, or dry eye, is the most common manifestation. Scleritis is the most serious. And hydroxychloroquine toxicity, used to treat RA and lupus, causes a characteristic bullseye maculopathy, screened with OCT and 10-2 visual field testing. In ankylosing spondylitis, recurrent acute anterior uveitis is the most common extra-articular manifestation, strongly associated with HLA-B27 positivity.
We close this masterclass with the most current innovations in ophthalmology and a final board cheat sheet to lock in those last-minute associations. Starting with the innovation horizon. Artificial intelligence in ophthalmology is no longer a future concept. It is here. The FDA has cleared IDX-DR and IART as autonomous AI systems capable of screening for diabetic retinopathy in primary care settings without requiring a clinician to review the images. The 2024 AAO position statement now officially endorses AI integration into clinical pathways for diabetic eye disease screening, a seismic shift in how we approach preventative ophthalmology at a population level. Gene therapy continues to advance. Luxturna, voretigene neparvovec, now has 7-year durability data, confirming sustained improvement in visual function for patients with RPE65-associated inherited retinal dystrophies. This is one of the most exciting long-term success stories in all of medical genetics. For presbyopia, Vuity, pilocarpine 1.25%, was FDA approved and works by reducing pupil size to increase depth of focus, with a peak effect at 15 minutes and duration of approximately 6 hours. For glaucoma, minimally invasive glaucoma surgery, MIGS, continues to expand, with the iStent and Hydrus microstent now established as options for mild to moderate glaucoma. Now your final high-yield board match table. Commit these associations to memory. Cotton wool spots, arteriolar occlusion, seen in hypertension, diabetes, and HIV. Bullseye maculopathy, hydroxychloroquine toxicity, screen with OCT. Argyll-Robertson pupil, accommodates but does not react, neurosyphilis. Homonymous heminopia with macular sparing, occipital cortex or PCA territory lesion. Bitemporal heminopia, pituitary adenoma. This is ophthalmology, and now you own it. Please like this video, leave a comment below, share it with your study group, and subscribe to MedStudios for more high-yield medical content updated with the latest guidelines. See you in the next one.